in these cases, I use the radial artery from the trunk of the STA to the distal ACM. And another thing we consider before surgery, ischemic complication, sometimes reported. It's a terrible complication because we do the temporary clips sometimes, so that cause the ischemic. So before attacking to the aneurysm, I made the IC bypass first, then attack to the aneurysm. So I named it hemi-bonnet insurance bypass, SDS, RA, and ACA. I experienced 3 cases for last 5 years. 22 male presented with bilateral visual acuity loss and bitemporal hemianopia. CT angiography showed huge aneurysm in the pituitary fossa. MRI showed partially thrombolized 35 millimeter size. And aneurysm exists mainly left side A1, A2. So I suppose right side I can trap, right side anterior communicated artery I can creep. So the first I try to make insurance bypass to the left side, then attack to the aneurysm. So this is the schema of the this operation. I'll show you the operation. Supine position and the bicoronal skin incision. Now I suture the radial artery to the ACA, then radial artery to the STA. The distal AC deconstruction and the right side ECOM already clipped, and then left A1 and A2 temporarily clipped. So that make trapped, and then cut the aneurysm. The inside the old clot replaced as much as possible, and then finally temporary clip replaced to the permanent clip, Sugita clip. And ICZ showed the patency of the right A1 and A2, and the bypass patency also I can confirm. So after operation, the patient condition is very good, and visual acuity recovered well, almost normal. And CTA angiography showed no residual aneurysm, also the bypass patency. MRI showed no ischemic region. He was discharged as modified Rankin scale 0. Next case is a 40-year male presented with dull headache. MRI angiography showed tumor aneurysm at the anterior communicated artery site, and MRI showed these two aneurysm kissing. And MRI also T1, T2 showed the right side aneurysm is supposed to be partially thrombosis. And CT angiography showed the left side A1 is a kind of azygous artery supplied to the right, both right A2 and left A2. And right A1 only supplied to callous marginal artery. So at least I reconstruct the right side the callous marginal artery. So first, I suppose to reconstruct the right side callous marginal artery reconstruction. This is the schema of the operation. I showed the video. So radial artery anastomosis to the callous marginal artery. The proximal side of radial artery anastomosis to the proximal side of the STA. So bypass patency is confirmed. After that, attack to the aneurysm. Right side aneurysm removed and the A1 trapped. Distal A1 also trapped. And then the kissing part dissected. So left side aneurysm dissect from the right aneurysm. Fortunately, left side aneurysm can occlude at the neck. So I can do the neck clipping. A little bit regional aneurysm neck. I can clip another Sugita clip. After the operation, the patient uneventful. So the post-operative CTA show no regional aneurysm and the bypass patency. Post-operative MRI showed a small ischemic lesion, but he suffered no neurological deficit. So he discharged as modified Rankin scale 0. The third case is the most huge aneurysm case. 40-year female presented with dull headache. MRI showed partially thrombed size 51 millimeter aneurysm, mainly at the left side frontal base. MRI showed CT angiography showed aneurysm mainly exists to the partial thrombosis of the CTA only showed the right side, but mainly at the left A1, A2 junction. So this is the schema I proposed to the operation. So at least I should do deconstruction the distal side of A2 or left side. So first I reconstruct the A2, left side A2, then attack to the aneurysm. I show the operating video. The first, the left A2 anastomosis to the radial artery. The radial artery anastomosis to the STA. The bypass patency is confirmed using the ICG videography. Then attack to the aneurysm. This is the neck of the right side here. Fortunately, the clip is replaced the neck of the aneurysm, including the left A2. The two Sugita grip used for secure the distal blood flow. After that, aneurysm cut, but very hard. So organized clot removed by using the QSA. After that, the temporary grip replaced to the permanent grip. After the operation, CT angiography showed a non-residual neck and also the bypass patency. MRI showed no ischemic region. After the operative course is uneventful, she was discharged as modified ranking 0. All cases I have experienced, everyone discharged good recovery. STA is very good to donor, but distal side is good enough to supply the both ACA, but the proximal side reported is enough to supply the blood flow. So I think proximal side STA is good for the donor. And also Dr. Zhu showed the STA is expand according to the flow demand. So that's a good thing about the STA use. And I also didn't occlude the distal side of STA, distal to the anastomosis side. Distal STA supply to the skin, so less skin trouble, I think. STA, RA, and A3 insurance hemibonet bypass is, I think, very useful for the treatment of ACA partial thrombus aneurysm. Thank you very much.
Thank you, Professor Vada, for a nice disposition of managing very complicated ACOM aneurysms. Any comments or questions? Dr. Mehta?
Thank you very much. Yeah. No need. Usually the supine position and 3-point fixation are used. Later. Yeah, later. No, not necessary. So, but I made a little bit of gata on the bone, and also the titanium protection device put on the radial artery.
If not, there are no questions. Thank you very much, Dr.
May I request Professor Yasuhiro Sanada? Professor Sanada. He will speak on salvage technique for bypass graft occlusion.
Good afternoon, everyone. I'm Yasuhiro Sanada from Keitai University, Osaka, Japan. I really appreciate to have this opportunity to present here. Today, I would like to talk about the salvage technique for bypass graft occlusion. Well, bypass graft occlusion is one of the most serious troubles in bypass surgery, and this can happen intraoperatively as well as postoperatively. And I would introduce salvage techniques for occluded grafts. So let's check out the cases. Case 1, postoperative bypass occlusion. Yeah, this case is a 79-year-old man with left IC occlusion, and he presented transient right hand paralysis. And the MR angiography revealed left IC occlusion. And this is a preoperative angiography revealed a good. He had the thick STA branch. And my colleague performed left STA-MCA bypass. But unfortunately, on the next day, the bypass graft was occluded because of the kinking of the graft around here. But luckily, this patient presented no symptom at this time. So we just watched. But 1 week later, the patient presented right hand paralysis and motor aphasia, and the DWI revealed ischemic area on the inside cortex and temporal lobe. So we determined the M2 branches were also thrombosed together with the bypass graft, and then we decided to reconstruct the bypass. So we planned the bypass reconstruction with radiatory graft. Usually the radiatory graft was placed in between the MCA and the ECA, but in this case the brain was ischemic. This ordinary procedure can cause the hyperperfusion, so we planned to place the radiatory graft between the MCA and the superior siloid artery, like this. And oh, excuse me. This is the movie. After reopening the scar, the bypass was totally thrombosed. Now opening the cerebral fissure, the M2 branch was also thrombosed. So I transected the bypass and then squeezed the clot out of the recipient artery until the backflow was encountered. And the backflow was identified. I ligated the bypass. After these procedures, the radial artery graft was anastomoted to the proximal site. And after this anastomosis, the other end was connected to the superior siloid artery. Here, this is the superior siloid artery, and then the other end of the RA graft was connected like this, and then the new graft was reconstructed. After this reconstruction, the propagation of the ischemia was stopped, and the MR images revealed a good bypass patency, but even in this setting, minor bleeding was occurred in the ischemic area. Next case, this is also postoperative bypass occlusion. This case is a 63-year-old man with left IC occlusion. He presented transient with athia. The same guy at the previous case performed the left STMC bypass. Oh, excuse me. The bypass was well demonstrated on the next day, but 2 weeks later, the bypass was occluded. And maybe this was also maybe a bypass graft kinking around here. And lucky, he was very lucky, and this patient presented no symptom at this time. But he was very unlucky, and 1 month later, the patient presented right hand paralysis again, and angiography revealed bypass was occluded, but the ST trunk was somewhat painted. This may be because of the small punch was painted around here. So we planned bypass reconstruction with radial artery again, but we could not do that because his left subclavian artery was occluded and his right side Allen test was negative. So we gave up using the radial artery graft and we planned bypass reconstruction with the occipital artery graft. So we harvested the occipital artery that was connected to the SJ trunk, and then this graft was connected to the MCA. This is the movie. First we harvested the occipital artery, then we reopened the scar, then we found the bypass kinking and the graft was totally thrombosed. Here. And I opened the cerebral fissure, as I showed in the previous case. The bypass was transected, the clot was squeezed out until the backflow was encountered. The other branch was also done in the same procedure. And these M2 branches were patent. And then I anastomosed to the occipital artery graft to the ST trunk. After this, the other end of the occipital artery was anastomosed to the empty branch. And this is the final view. The ICZ revealed good bypass patency. After this bypass reconstruction, his TIA was gone, and the angiography revealed the MCA area supplied well. Oh, excuse me. Post-operative DWI revealed no ischemic major complications, and the MR angiography demonstrated good bypass patency. This is the final case. This is intraoperative bypass occlusion. This patient had azygous ACA stenosis, but several years later, this stenotic artery was occluded, and CVF in the bilateral ACA area was decreased, so we planned ACA bypass. So first we planned STA ACA bypass, but in this patient had the single branch STA and the thick posterior auricular artery. So we designed the skin incision like this, starts in front of the tragus, and the runs above the posterior auricular artery, and then this part is in the midline. So after this skin incision, we harvested the posterior auricular artery that was connected to the STA, and this extended STA was anastomosed to the pericardial artery. This is the movie. Then after dissection of the interhemispheric fissure, bilateral pericardial arteries were exposed, and the ICG videography revealed reticulate black from back side to the front side. And then a posterior auricular artery graft was anastomosed to the one of the pericardial artery. And after this anastomosis, the other end of the posterior auricular artery graft was connected to the STA. The ICZ revealed the good bypass patency. This bypass looks good so far, but some guy put the bypass after this. Yeah, that was me. Anyway, yeah. After pulling the bypass graft, so the bleeding occurred at the state suture site. So I put the temporary clips, these arteries, and then I managed to the resuture the state suture point. But this procedure caused the bypass graft occlusion. So I made a small incision around the anastomosis site, and then squeeze the clot out of the recipient artery until the backflow was encountered, like this. So squeeze, squeeze, squeeze until the backflow was encountered like this. And of course, the clot in the STA, in the graft, was squeezed out. And finally, the small incision was resutured. Then the bypass was salvaged. After MR angiography revealed good bypass patency, and luckily this patient had no major complications. Through the three cases, in my experience, the main cause of the graft occlusion is thrombosis, usually derived from graft kinking. So if we find the graft thrombosis before intraoperatively, if we find the graft kinking before thrombosis, all we have to do is just repositioning the graft to solve the kinking. If we found thrombosis and graft thrombosis intraoperatively, now we have to perform the thrombectomy, like in the final case. If we find graft thrombosis postoperatively, and the patient deteriorates ischemic symptoms, so we have to perform bypass reconstruction with thrombectomy in the recipient artery. So we have to do this bypass reconstruction as soon as possible. Conclusion. Bypass occlusion can be salvaged in some cases. The success depends on whether the clot can be removed out of the recipient artery. So the best way to avoid these situations is, of course, careful handling of the bypass graft. Thank you for your attention.
Thank you, Professor Sanada. On the topic is open for discussion. Yes.
What is your cause that has been occluded? And second time, it is the surgery. If it's again occluded, what will you do?
Excuse me, so I can catch you.
First thing is that what was the cause that it was occluded intraoperatively when you operated your first surgery?
Yeah.
And second is that when you have finished the second surgery, what is the possibility of again recurrence of occlusion? And how do you prevent that?
The main cause of the bypass occlusion is maybe a graft kinking. It's not a technical problem of the anastomosis. Just when you close the skirts or just put the bone flap, then that graft was sometimes it's kinked. So the graft was occluded. But the maybe a second question is maybe a surgical timing. Again means yeah. Sorry, I can't catch what you're talking about.
Second time, you are done second surgery.
Yes.
Done the salvage job.
Uh-huh.
Again gets blocked.
Is there any possibility?
Yeah. Of course, if there is a possibility, but we really pay attention to not to kink the graft. That's it.
I have a question for you. What is the time window between the bypass
perform
and then
operation.
going back again? Because usually in TPA we have a time windows. Here, when you are revascularizing, is there a time window?
No, I can't clearly explain the time window of the second surgery, but the timing should be as soon as possible when we find the patient deterioration.
I mean to say, in the first case, you have shown MR evidence of infarction or ischemia already established. Usually, in such cases, the TPA is not given because it is contraindicated. The hemorrhage can be there.
Yeah, exactly.
So here you have done a bypass, trying to increase the blood flow. Is there a potential of hemorrhage in such cases?
Yes, of course. So I just showed the small hemorrhage in the temporal area. But this patient presented autophagia, but the DWI demonstrated small ischemic lesions in the temporal area. So we decided to reconstruct the bypass. And using the radiatory graft, usually called the hyperperfusion. So we decided to place the graft, yes, it's superior, exactly.
Thank you.
Thank you, Dr. Sanada, for the beautiful presentation.
Thank you.
Now we'll go for the next paper, surgical rescue technique using small bone piece in case of the incomplete burrow with craniodome. Professor Toru Yoshihara.
Good evening, everyone. I'm a resident of neurosurgery. From the bottom of my heart, I'm most grateful to have been given this opportunity. Today, I represent the dealing of incomplete bowel. Introduction. We sometimes experience of incomplete penetration of bowel because of osteoporosis in the operation of the elderly people. We have to add another bowel to the neighbor, drill the internal table, or change to a smaller operator. However, it takes more time and may sometimes cause the dura mater tear. We present an easy method to recover an incomplete bowel safely and surely by using a small bone piece. Operative technique is 1, 2, 3. It's too simple, only 3 steps. First, make a 5 mm size small bone piece of outer table using plunger. There is an incomplete bowel. Take the bone piece along the cutting line because there are few bone defects. Second, put the small bone piece in the center of the incomplete bowel. Sorry. So, the center of incomplete bowel. Last step, complete bowel. There is knack in doing it. Push a craniotome on the small bone piece until an inner drill connects with the axis of the drill. Unlock the safety stopping function. I'll show the point by a movie. Right front temporal craniotomy. During perforation, it stops and doesn't work again. So I take a small bone piece and put the center of incomplete bowel. Then I try again. Before start the perforator, I push it. Then start it and complete the bowel. So tips is just push and start. This is the most important point. Discussion. Craniotomy consists of two laminar structure, outer drill and inner drill. It begins to turn connecting with the axis of the drill drive by pushing the inner drill tip. Then, a safety stopping function works naturally when only the inner drill reduces the resistance. In the case of incomplete bowel, in the case of incomplete bowel ventilation, the resistance of the inner drill disappeared. It's impossible to use the drill to finish ventilation. Putting a small bone piece inside the incomplete bar hole, it recovers a resistance of the inner drill, and the safety stopping function is unlocked. Then, perforator returns again and bar hole is finished ventilation. Another method was reported in 2017 operative neurosurgery. In this method, they use a bone pad at the bottom of the other bar hole. This is the bone pad. It's relatively thick. Then put the reversed bone pad on incomplete bar hole and complete the bar hole. But this method needs another completed bar hole and thick bone pad. In contrast, our method has a lot of merit. One few bone deficits that make a new bar hole, time assuming we do not need to change the attachment. Safely complete a bar hole. So let's try this method. Thank you for your attention.
Thank you, Dr. Ishida, for a nice technical note on how to overcome technical problems we normally encounter once in a while doing craniotomy. I think we all have faced, but I think your new technique is a one can try. Normally, what we do is probably many of you in the western part of the world may not be still using Hudson brace. Sometimes we go back to our old friend Hudson Koklata and complete the burr hole in those such circumstances. But from now onwards, I will try to use your new technique. Thank you very much, Dr. Mukta.
But if this happens, we use a pediatric bar and do it. Instead of adult bar, we take a perforator with pediatric, smaller size.
Pediatric, yeah.
It works.
Thank you.
You understand the question?
分かってなかったです。
What he
Pardon?
said, that without using technique, I think what he was saying, he put in pediatric.
Smaller perforator.
And
Small
then he
perforator.
probably makes it complete. So what's your opinion about it?
すみません、誰か助けてください。
Professor.
That's a good idea. But another bubble, same bubble, instead of adult, use the pediatric bar.
It's
Perforator.
But right, we change it. What I'm saying is, the adult one gets blocked. It's not the time pediatric one is blocked.
Well, after my friend Professor Mehta, is there no danger? Of course, in your hand, nothing is dangerous, but in junior inexperience, if you put a pediatric bar hole, there is a danger. It will be gone in the middle of the brain. If there's a safety, because the adult bar hole is a big one. Even a pediatric bar hole, if it touches the dura, it will stop. I did not know that, but my experience was almost Hudson brace. So many times I put inside the brain. Yeah. Okay. So, okay. That's good.
Any other comment? Thank you very much. Yeah, I think, yeah. I think we had a wonderful session covering many aspects of the role of bypass, especially in Moyamoya disease and later on in thrombosed aneurysms, and also how to manage the occluded bypasses. Again, it reiterates that all of us as neurosurgeons should have knowledge and techniques to do bypass surgery, because first start in the lab and then practice in the patients. I think it should be a part of the evolving process of any neurosurgeon in the near future. Thank you. Sepgupta?
What actually we heard, I heard these days, that bypass surgery is like a heavyweight boxing, and it needs a lot of skill and a lot of practice and a lot of kind of going in. And even if that people like Binzu doing a 9 bypass a day maximum, and obviously thousands that he has done, obviously the other colleagues, other guests showed that if you get into trouble, there is a way out also. So therefore, I think that those who are interested in bypass surgery, but they not only felt that how to skill, how to experience themselves, young people, I think that they have got to, the way that they have learned, the young people will have to learn in the same way. There is no shortcut of in a bypass surgery, casual one, occasional one, and then if somebody is doing a 9 a day, that means that obviously he has excelled himself. And if he gets into trouble, the other guests told us what to do. So I think is that this is a very important and important kind of a lesson that we are getting from the master bypass surgery people to also how to rescue them if there is a problem. So I think that this is a very, very important thing. And also, eventually, for me, it is a very good one that if we get into part of problem, what to do. And so I think that this is very good. Now, what we said, we'll have a kind of a break for a rest room break. I mean, if anybody want to go to the toilet or something, and this is that time, and the tea and coffee are continuously available outside, and also then after that we shall start the second session, maybe at 3 o'clock. Second session is 3 o'clock. Fine. Okay.